Welcome to this Clinical Explainer. We're going to be tackling a really critical pediatric emergency, the management of button battery ingestion. Our goal here is to do a focused review of the evidence-based algorithm for what can be a devastating but definitely manageable clinical scenario.
All right, let's dive right in. We're going to structure our review by following the clinical decision pathway, starting from the initial presentation and workup, all the way through to definitive management and final disposition.
So we begin with that initial patient evaluation. The actions taken in these first few moments are absolutely paramount. They really set the course for the entire, and often time-critical, management pathway. Now, what's really fascinating here is how this entire, pretty complex management strategy has been distilled into a single, validated clinical algorithm. This flowchart is going to be our guide as we navigate each decision point. It's really the foundation of our entire discussion. Okay, so the first and most crucial step is just maintaining a high index of suspicion. As you can see, the presenting signs, things like stridor and drooling, can be notoriously non-specific. They often mimic common conditions like, say, viral croup or gastroenteritis, and that's what makes a thorough history and physical exam so essential.
Once that suspicion is raised, immediate radiological investigation is mandatory. We get both anterior, posterior, and lateral radiographs. Why? Well, it's not just to confirm the ingestion, but more critically to pinpoint the battery's exact location. As we're about to see, its position, whether it's lodged in the esophagus or has made it to the stomach, is the single most important factor determining the urgency of our response.
And that brings us to the first and most critical branch point in the algorithm, an esophageal location. A finding like this immediately escalates the case to a true medical emergency.
So, the crucial point is this. An esophageal button battery has to be removed emergently. We're talking a strict goal of endoscopic removal within 2 hours of ingestion. And that isn't just a recommendation, it is literally a race against the clock. Even in a patient who looks fine, who is totally asymptomatic, the battery's electrical current is rapidly causing liquefaction necrosis. The tissue is essentially dissolving, which can lead to perforation and some truly catastrophic complications.
This slide just powerfully illustrates that urgency. Standard pre-procedural fasting, NPO status, gets completely overwritten. Removal is never delayed. We can actually try to mitigate some of the ongoing injury by administering agents like sucralfate or honey, which can coat the battery and help neutralize the local pH. Then, during the endoscopy itself, a really thorough mucosal inspection is critical to assess the extent of the damage, because that's going to directly guide our post-procedural management.
Now let's explore the management pathway for those batteries that have successfully made it past the esophagus and are now located in the stomach or the distal GI tract.
So the first critical question in this pathway isn't about the battery itself. It's about whether a magnet was co-ingested. This one single data point from the patient's history dramatically elevates the risk profile of the whole situation.
Right. If a magnet is present, immediate removal is mandated. The risk of pressure necrosis, fistula formation, or even perforation between the battery and the magnet across different bowel walls is just unacceptably high. You have to intervene, regardless of symptomatology.
Okay, so in the absence of magnet co-ingestion, the next decision point in the algorithm is all about the patient's clinical status.
The development of any signs or symptoms, we're talking abdominal pain, vomiting, or any evidence of GI bleeding that necessitates prompt endoscopic removal. And if the battery is beyond the reach of the endoscope, a surgical consultation is definitely warranted.
Now, for the asymptomatic patient, management gets stratified by two key factors: the patient's age and the battery size. As this slide shows, younger children or those who've ingested larger batteries, over 15 millimeters, require a prophylactic endoscopic removal. In contrast, older children who swallowed smaller batteries can often be safely managed as outpatients.
For patients that are discharged for outpatient management, a clear follow-up protocol is absolutely essential to ensure safe passage. This involves diligent stool inspection. If passage isn't confirmed, a repeat radiograph is obtained around day 4. And a battery that just stays in the stomach beyond 10 to 14 days, well, it's unlikely to pass on its own and warrants consideration for endoscopic removal to prevent potential complications down the line.
Let's now move to the post-procedural phase. We're going to focus on the critical steps to ensure a safe patient recovery, particularly after the removal of an impacted esophageal battery.
After the endoscopic removal of an esophageal button battery, the key determinant for what happens next is the presence, and really the severity,
of mucosal injury that was noted during the procedure.
Here we see the two very different post-procedural pathways. Any visualized mucosal injury means admission for close observation. Why? Because severe complications like esophageal perforation or fistula formation can be delayed. They can appear hours or even days after that initial injury. On the other hand, in the absence of any endoscopic evidence of injury, the patient can typically be safely discharged home.
For those admitted patients who are stable and don't have evidence of perforation, a structured dietary progression is initiated. However, there should be a very, very low threshold for ICU admission for any signs of instability, respiratory compromise, or any other developing complications.
Finally, let's just distill this entire algorithm down into the most critical, high-yield points that should really inform your clinical practice.
These are the 4 crucial takeaways. Remember, an esophageal location is an emergency. Magnet co-ingestion is an emergency. The management of gastric batteries is nuanced and it is algorithm-driven. And finally, post-procedural care is dictated by the degree of mucosal injury.
And this leaves us with a final, and I think provocative question that really extends beyond individual patient management. As clinicians, we have to ask ourselves, what systemic improvements can we champion? How can we optimize our triage protocols, our inter-facility transfer processes, our operative suite availability to make sure that every single child with an esophageal battery meets this life-saving 2-hour therapeutic window? Thank you for joining this Clinical Explainer.